I'm Amit Goyal. I'm the Chief Investigator of the POSNOC study, and I'm an oncoplastic breast surgeon working at Derby. I would be delighted to take any questions about the POSNOC study.
Talk a lot about the lymph nodes, and in the patient information sheets it mentions the first one or two when the biopsy is done. How many lymph nodes do we have?
All women will have around a dozen lymph glands in the armpit. What we do at the time of surgery at the time of breast surgery is, we remove the first one or two lymph glands, which are the lead lymph glands, and these are called the sentinel lymph nodes. What we know is, from previous trials, is that breast cancer spreads to the lymph glands in a stepwise fashion. What I mean is, it goes to the first one or two lymph glands first, and then it goes to the remaining lymph glands, which are higher up. Okay. So what the surgeon does is, takes these lead lymph glands out and tests them for cancer. Mm-hmm. If they are clear, they don't have any cancer spread, the surgeon knows that the cancer would not have crossed them and gone to the remaining lymph glands. So those patients do not need any further treatment to the armpit. But if there was a woman who had cancer in these lead lymph glands, then potentially the cancer could have crossed them and gone to the remaining lymph glands in the armpit. And that's the reason those women are offered, at the moment, outside a trial, further treatment to the armpit.
Okay, and what do the lymph glands do exactly?
Lymph glands are present in other areas of the body as well. And basically what they do is, they're part of the body's defense shield or a defense system against infection.
Do you know how many women actually get lymphedema?
Yeah, approximately 1 in 5 women actually have a risk of lymphedema or will get lymphedema in their lifetime. And the most important thing with lymphedema is that it's not that it will happen in the first year or 2 years after surgery or radiotherapy to the armpit. It can actually happen years after your armpit treatment. And that's the reason it's so much important to do this trial. Because if there is no additional benefit to women in having armpit treatment, then we shouldn't be doing this. But that's what we don't know. And that's what the trial results will tell us.
And what are the actual symptoms of lymphedema, apart from I've heard a swelling arm? Are there any other symptoms? I presume it's painful as well, is it?
Yeah, lymphedema, which is arm swelling, as you rightly said, will cause swelling, which is visible. And the other things it will cause is sometimes more, even if the swelling is not visible, a woman may complain of heaviness in the arm, and maybe pain, ache, discomfort in the arm, maybe difficulty in moving the arm, some impairment in functions.
And is there any treatment for the lymphedema?
We can offer things to control it. For example, compression garments that basically push the fluid or help to milk the fluid back to the body from the arm to reduce the swelling. But unfortunately, there's no cure. And that highlights the importance of the study.
Going to the gym or sports or anything, are you stopped from doing that?
If a woman wants to have lymphedema or arm swelling and other symptoms, she can probably still go to the gym, but it all depends on the symptoms she has, the degree of functional impairment she has.
And how bad it is.
And how bad it is, and what kind of activity maybe. She may not be able to do a particular activity in the gym, but yes, she may be able to do something else in the gym.
So if I were in the group where I had the lymph nodes removed, would I have to be careful for the rest of my life in the activities I did if I was to get a bee sting or had blood pressure taken or lifting cases? Would I always have to think about that?
That's very correct. Because once you have lymph glands removed completely from your armpit or radiotherapy to your armpit, the damage is permanent, I'm afraid. Or the risk that you have, the potential risk, is lifelong. And we advise patients routinely to be careful with that arm, because you're at risk of lymphangitis, which is basically the arm swells up, becomes red, hot. So we advise that when you're gardening, put gloves, make sure any small cuts, you have to be careful. So yes, that risk is lifetime.
Gosh, yeah, thank you.
And did I understand you correctly? Did you say that lymphedema can occur at any time after surgery? But this study is only going to last for 3 years. So is it really relevant?
I think it's a very important question. You're correct in saying that the risk of lymphedema after treatment of the axilla it can last for a lifetime. And arm swelling can happen even many years after surgery. In the study, in the post-hoc study, we will be measuring these outcomes, whether the woman is getting side effects like arm swelling for the first 3 years. We would have liked to measure these side effects over a longer term, because in the study itself, patients are being followed up for 5 years. But unfortunately, for such a big study, we need a lot of resources as well. And because of resource restriction, we had to curtail it to 3 years. But yes, we would have liked to actually measure them over a longer period of time.
Okay.
I play a lot of golf, and I just wonder if I agree to the trial, is there any possibility I can not have the armpit treatment? Because the side effects that you talked about, I don't like the idea of the stiffness of my arm, and is there any possibility?
No. And the reason for that is, the reason we are doing a trial, the post-hoc trial, is because we don't know. We don't know whether actually omitting the armpit treatment is safe or whether it's needed at all. And that's the reason we are doing this trial. We need to find the answer to that. And the only way we can find an answer to that is to actually randomly allocate patients to the 2 treatment arms. But if you were to participate in the trial, you have a 50% chance of not having the armpit treatment.
If I move, then it would be up to myself to notify you of my new address, so I could still continue in the study. But what about being seen by someone? The study is not just all questionnaires, is it?
No, you're correct. The study is not all about questionnaires. The questionnaires are addressing quality of life, to know how, your various aspects of quality of life. But apart from that, we need to know by checks, regular checks, whether the cancer has come back, any side effects you may have of the treatment, and that will be monitored on a regular basis. So if you move, as long as your own hospital team will arrange a future follow-up from a cancer perspective with the new team in your own locality.
Good.
The information said something about quality of life. What is that?
Yeah, quality of life is very important. In simple words, what it means is how well a woman feels, and is she actually able to carry on her daily activities, what she likes to do, and whether she's anxious. And so it's a multifactorial. But to sum up, I think I would say it's how a woman feels. And that's very important. Any treatment that we offer, or we shouldn't be doing more harm than good. So in this trial, especially because we are actually in one group, we are saying that those patients will not be having any armpit treatment. It's very important to check if those patients, maybe they're more anxious afterwards, that actually I didn't have the armpit treatment. Does it mean that the cancer is going to come back again because I've actually had a lesser treatment? Do they actually keep worrying about that and are not able to carry on with their daily activities? We need to check that. And to check that, we have some standard questionnaires that we use, which have been used in previous trials. And this will be coordinated by our quality of life team, which is SHORE-C. And there are other quality of life questionnaires, which again ask various questions pertaining to your daily activities, whether you can do a particular thing you like, how you're feeling, and they capture that information. And so this information will be captured in the 2 groups of the trial, and we'll be seeing whether quality of life is better in one particular group or whether it's the same.
Okay, so and how often do I have to do these questionnaires? And I'm actually not all that keen on questionnaires. How long will they take to complete?
The questionnaires, you'll have the quality of life questionnaires, the initial questionnaires before you start the trial, but have consented for the trial, you'll be asked to fill those questionnaires in the clinic when you see the research nurse or your one of the research team members in the hospital. You'll fill those questionnaires there, and each questionnaire shouldn't take more than 5 to 10 minutes to fill. Following that, you will be posted those same questionnaires after your surgery at your home address by the Quality of Life team, and those questionnaires can be posted back to them there will be a self-addressed envelope which is stamped, which will be sent along with the questionnaires to you as well. And these questionnaires shall be sent to you at 3 months, 6 months, 1 year, 2 years, and 3 years.
If the cancer comes back, or spreads, what would happen then when you're in the middle of the study?
If the cancer was to come back, you will be given treatment appropriate to where the cancer has spread to, and this will be discussed with you by a hospital team. With regards to the study, yes, all the information that we have collected from you, we will still like to use that for the results of the study. And the fact that the cancer came back in a particular person, that's an important endpoint for the trial as well, because we would like to know in both groups of the trial in how many women the cancer came back, maybe in the armpit and elsewhere.
I'm in the OSNA group. I don't like the idea of having treatment decided for me whilst I'm in theatre under general anaesthetic. Could you help me there?
Yeah, sure. I mean, these special tests like OSNA, and some hospitals have a different test called medicine. The advantage of these tests is the surgeon knows the results, whether the lead lymph glands he or she has removed, whether they have cancer or not, at the same time when he's doing the first surgery. And the advantage is for patients is if those lymph glands are clear and don't have cancer spread, the surgeon doesn't need to remove the remaining lymph glands. However, if those lymph glands, the lead lymph glands, have cancer in them, the surgeon can remove the remaining lymph glands at the same operation. So if you were in the trial and you were randomized or allocated the group of auxiliary treatment, your surgeon will be able to remove the remaining lymph glands if your lead lymph glands had cancer at the same operation. And this actually avoids an unnecessary second operation. Yes, I agree with you, it needs to be balanced against the uncertainty. But the advantages with this technique are you don't have a second hospital admission, you don't have to go under the anesthesia a second time.
I'd rather be woken up in theatre and told if my cells have cancer in them. Is that possible?
Yes, the patient is the most important person. And that's what I tell my patients in the clinic, that it's what you decide. I can give you information and help you decide. But if that's what you wanted or a particular patient wanted in hospitals like yours, which can actually test the lymph glands at the same time when you're asleep at the first operation, yes, the surgeon will do that for you or will be able to do that and discuss it with you. But at the same time, you need to remember that the disadvantage of doing that is that you have to undergo a second anesthetic if you participate in the trial and you were allocated a group which needed further treatment to the armpit. So you needed a second anesthesia to undergo axillary lymph node clearance, which is removing all the remaining lymph glands, a second hospital admission. So yes, we can do that for you, but as I said, you need to balance it against the other problems with that approach as well.
Thank you.
My hospital actually performs the OSNA therapy study. If I said to them that I would rather go into the POSNIP group, could I not be, tested under the OSNA?
If I'm understanding it correctly, I think what you're asking is that you'd rather know the results of your lead lymph glands or the sentinel lymph nodes first, and then be able to decide whether you would like to go in the study or not.
Yes, yes.
Yes, I think I see no reason why a hospital doctor or your surgeon can't do that for you. because it's a matter of patient choice. So please discuss it further with your surgeon.
I'm Dr. David Dodwell. I'm a clinical oncologist. I work in Leeds, and as you all know, I'm very much involved in the POSNOC trial. You have some questions for me, and of course I'll do my very best to answer them. So who wants to fire away first?
And why can't we just choose what we want rather than be randomised?
It's a very good question. It's not an easy one to answer, and I know that the concept that treatment is chosen not by the doctor and not by the patient is contrary to the normal way that one expects the doctor-patient relationship to work. The reason that I couldn't choose a treatment, or if you were a patient, you couldn't choose the treatment, is the worry that we would have about introducing this thing we call bias. And what bias means, and I know it's a slightly techie word, it means the worry that I might be choosing patients for a certain treatment based on my level of worry about that patient or other factors. And that patients might choose a treatment in a different way that might introduce this thing called bias. So if we allowed patients or doctors to choose which treatment to go in, that would spoil the results. Now, of course, if you have read all the information about the POSNOC study, I know you've done that, if you've spoken to the surgeon or the oncologist that works at your hospital, and you really had a strong preference for which kind of armpit treatment seemed best for you, then it wouldn't perhaps be a good idea to go into the study, really. It would be better to have treatment outside the study, and you might feel more comfortable with that. You shouldn't go into the study if you're going to worry a lot about which particular treatment has happened. It will be better not to be involved, I think.
If I'm a patient not having the armpit treatment and I suddenly decide, really, I'd like to have that treatment, do I stay in the study or can I come out of the study?
The information that we had gathered from you would still be important for the study. So so the answer to the question, I think, depends really on where we are in the patient journey. If we allocated through the trial a particular treatment and then you didn't want to go down that route, then we wouldn't proceed further. If, however, you made a decision 12 months or a year or two later that you didn't want to be involved in the study, of course, that's entirely your choice, but we would still like to use the information that we'd gathered to that point in time, if you would allow that. You are, of course, completely at liberty to come out of the study or not to go into the study for any reason, and you don't have to tell us why. And whatever else would happen, we would look after you, or your hospital and the team would look after you to the best of their ability and have a discussion with you about the rights and wrongs of any other treatment that might be appropriate at that point in time. But it would depend really on the point in the journey where you were, I think. Right. I think if anyone is thinking about going into the study and is really worried that they might pull out after only a few weeks or a few months, it's probably better not to do it.
If I was in the group that didn't have armpit surgery, how can I be convinced that, would there be extra checkups in order for me to feel confident that the cancer wouldn't spread? So would there be extra checkups, extra clinic visits?
No, there wouldn't, is the short answer really. And the reason why there wouldn't goes back to that thing called bias. If we had a situation where one group of patients were having a very different level of follow-up to the other group of patients, because we're looking more often and harder, we would probably identify more problems, not necessarily from recurrence, but from other problems, lymphedema or other side effects. We would pick them up more often, we'd deal with them, we'd intervene more. It wouldn't therefore be a fair comparison. So for the reason of not wanting to introduce bias, the follow-up schedule for the patients has to be the same. Otherwise things won't work. And that's a common source of bias in trials, and again can cause a problem with interpreting the results.
Thank you.
I'd be worried about not having the armpit treatment, but I'd still like to help with the research. Is there any way I can make sure of being in the group that receives the axillary treatment so I can still take part?
The short answer is it's very difficult to do that. The doctors that are involved in this study have to explain to patients like yourself that if you do go into the study, you have an equal chance of having armpit treatment, either with surgery or with radiotherapy, or having no armpit treatment. So it wouldn't really be possible to go into the study. I think if you were of that thinking, if that was your thinking, that was the mindset, it would be better not to go into the study, really. There may, of course, be lots of other studies that your hospital is running that might be more appropriate. Hospitals are often running many studies, or are encouraged to engage in as many studies as is possible and practical. So there might be options for other studies if you wanted to help in other ways, but it wouldn't be possible really to go into the POSNOC study. And you'd be better to stay out of it if you were sure that you had a very clear preference for a particular type of treatment to the armpit.
So if the cancer spreads, what would happen then?
I always hesitate before I say it depends, but it does depend on what the cancer is doing, where it is, how it's affecting you, how you are with it. If we're talking about a recurrence, the cancer coming back in the armpit, then the likeliest thing is that you would be able to have an operation at that time. But that would depend on other things, whether it was operable at that time, whether there was any evidence of spread elsewhere. If the breast cancer has spread elsewhere, then of course that's a bad thing. There's no avoiding that conclusion. And if the cancer has spread to other organs, then ladies with secondary breast cancer in that situation cannot be cured of their breast cancer, but the disease can often be controlled, and often for a long period of time. Now, the treatments that we might want to use to consider to control it at that time would very much depend on where the disease was, how it was affecting you, the type of breast cancer that it was, whether we could consider hormone treatment or not, whether chemotherapy was an option. Lots and lots of factors, really. But of course, cancer recurring is a bad thing, and secondary breast cancer can't be cured if that happens. But you will be treated by the team using all of their skills and all of the available treatments to try and keep you well as long as we could.
And would I remain on the trial?
We would still be wanting follow-up information in the study. We would still be interested to know how you were and the long-term outcome.
If the cancer has already spread to my lymph nodes, surely if I leave it, it will spread even further. Is that the case?
I can understand, how you're thinking about that. And cancers, of course, we know how they behave. They get bigger and they spread. Whatever armpit treatment we consider or you have within the POSNOC trial, the important thing to remember is we will be using very effective drug treatment as part of your treatment package, to put it that way. And the drug treatments we use, including hormone therapy, chemotherapy treatments sometimes, Herceptin treatments sometimes, are very effective. And modern drug treatment is so much better than it was 10 and 20 years ago. And drug treatment, we now know, is not just very effective at reducing the risk of secondary breast cancer, but is also effective at reducing the risk of a recurrence in the breast or in the armpit. And that, of course, directly relates to the POSNOC study. So whatever we do to the armpit, we will still be recommending drug treatment, which will be a part of the treatment program. And the question in POSNOC really is, and the hope is that that will be enough, and that we won't have to subject you to treatment to the armpit with either radiotherapy or surgery, which can have lots of problems in the years to come. That gets to the point of the whole reason to do the study.
Okay. Thank you.
If I have the standard adjuvant therapy plus the armpit treatment, would I then have surgery, radiotherapy, or both?
Well, obviously the adjuvant treatment refers to the drug treatment, the hormone therapy, possibly the use of chemotherapy or other drug treatments. But if we look at the armpit treatment, if you were in the group where you would have the armpit treatment, and that was how things had worked out in the trial, then you would either have an axillary node clearance done by a surgeon, or you would have radiotherapy done by somebody like me, the oncologist. But you would not have both treatments. Both treatments has very clearly been shown not to add anything and does very much worsen the risk of arm swelling, of lymphedema later on. So it would be radiotherapy or surgery. And that would depend on the practice and policy that was happening in the hospital where you were treated, who would discuss these options with you. And can depend on one or two other things. But it would be surgery or radiotherapy, but definitely not both.